Good morning, everyone. Today, the topic of discussion is approach to thrombocytopenia. In our day-to-day basis, we see a lot of cases of thrombocytopenia that are admitted with bleeding gums or purpura or petechiae in our hospital. They're coming into the OP and they're coming into IP. So today we'll discuss about the thrombocytopenia. How do we go about it at all? So we go on a case-based approach. So, a 21-year-old female presented with petechiae and purpura on legs and bleeding gums. Her platelet count is 20,000 and PTT, APTT are normal. Hemoglobin is 10 and iron deficiency anemia is present. So, she is a 21-year-old female presented with petechiae and purpura. Generally, all coagulation disorders present generally with the bleeds in the joints or muscle hematomas and all, whereas the platelet disorders generally present with mucosal bleeds, either GI bleeds or some petechiae or purpura, and bleeding gums. They are mostly mucosal bleeds. So, what is the difference between the vasculitic purpura and the ITP related, whatever thrombocytopenia related purpura? So, vasculitic purpura are generally present and on the non-dependent areas. So they can be present at anywhere. That doesn't need to be non-dependent. That doesn't mean to be dependent. Dependent areas like legs or buttocks or something. Whereas platelet-related purpura are generally present on the dependent areas, and also vasculitic purpura are generally pruritic and also palpable. So whereas thrombocytopenial purpura are generally not. There is no pruritus associated with thrombocytopenic associated purpura. So these are the differences. How do you differentiate between thrombocytopenia and vasculitis related purpura? Whereas vasculitic purpura is present in the non-dependent areas and more pruritic and palpable. So here it is clearly the platelet count is already 20,000. We know it is a case of thrombocytopenic purpura and bleeding gums. So the platelet patient has also hemoglobin of 10. So why this is important is, so generally so by now you know when you're looking at the case of thrombocytopenia, first thing you need to rule out is if there is any infection. Infections can cause thrombocytopenia, but not this low of thrombocytopenia generally, unless there is severe infection is there, any recent start of drug is there, or also patient is having any other autoimmune conditions like SLE or any Sjogren's or scleroderma, rheumatoid arthritis, or patient is having any autoimmune condition per se, or patient is having any associated renal failure or any, because microangiopathic hemolytic anemia associated with hemolytic uremic syndrome, TTPs, can cause low hemoglobin and low platelet count. You need to take all of this consideration before labeling it as any defining a particular cause. So here straight away patient doesn't have any drug cause, patient doesn't have any other CTT features as mentioned, and they didn't mention anything about the history, but you need to ask for them. So her platelet count is actually 20,000, her HB is also 10. So generally we go ahead and say it's a case of ITP. So what is ITP? Previously ITP was thought to be a case of idiopathic thrombocytopenic purpura, but recently they changed the name to immune thrombocytopenic purpura or immune thrombocytopenia. So there are two causes. The immune thrombocytopenia itself is classified into primary and secondary immune thrombocytopenia. Primary immune thrombocytopenia, where there is no definitive cause, where there is no, we don't know what is it is more like idiopathic cause. Whereas secondary immune thrombocytopenia is secondary to some other cause, any SLE, rheumatoid arthritis, infection, some malignancy, some systemic disorder. There is some CLD or something is there. So primary is no cause is found. So both, but initially it was thought to be idiopathic, but it was still thought there is some antiplatelet antibodies even in the idiopathic cause, that is the cause of thrombocytopenia. So it is more of immune thrombocytopenia right now. So this might be a case of immune thrombocytopenia, mostly a primary immune thrombocytopenia, since there is no other cause which is not mentioned in the case. But before labeling it a case of primary immune thrombocytopenia, so for secondary I'll discuss later. For primary immune thrombocytopenia, the RBC lineage and generally the leukocyte lineage should be normal, liver and splenomegaly should be absent, no lymphadenopathy should be seen, the response should be seen with steroids. So these are the defining criteria to label it as a primary ITP, where the patient doesn't have any secondary cause is the first thing. The patient should not have any change in there is no other hemolytic anemia or any other associated leukopenia present. The patient should not have hepatomegaly or splenomegaly or lymphadenopathy, and the patient should show response to the steroids generally. And generally, previously what is thought that in the cases of ITP, bone marrow examination is mandatory, especially in the elderly people, to rule out any myelodysplastic syndrome, because one of the classical presentation of MDS in elderly is isolated thrombocytopenia. But generally in them they have some dysmorphic features in the peripheral smear. And one more criteria criteria in the ITP is that generally should not be any dysmorphic features in RBC lineage or WBC lineage, or any blast cells should not be present in the smear before labeling as an ITP. So this is a case of primary ITP, since there is no other autoimmune condition associated, no secondary cause, no drug cause, no malignancy per se, no dysmorphic features, no dysmorphic cells in the, or no blast cells in the peripheral smear. Though the HB is low, but it is explained by iron deficiency anemia, since the platelet count can cause loss of blood. There can be menorrhagia, there can be mucosal bleed, there can be melena also. Maybe that is causing the iron deficiency anemia, that can be explained by the primary ITP, that is leading to the blood loss. So primary ITP this is the case. So in them, how do we go about the treatment in the case of primary ITP, whether you treat them or you do not treat them? So I'll explain those in the future slides. Like generally anything count less than 30,000, we generally go ahead and treat the case of ITP with initially with steroids if there is no significant bleeding. So though the life-threatening bleed is not there, only minor bleeding is there. Here, like in this case, only petechiae, purpura are there. No life-threatening bleed is there. We go ahead and start with corticosteroids. Either you go for pulse dose 15 to 20 mg per kg of methylprednisolone for 5 days, followed by 1 mg per kg of prednisolone. So you directly go with 1 mg per kg of prednisolone therapy, and you go it for 1 to 2 weeks and slowly taper it off in less than 6 weeks. So in less than 6 weeks, you need to taper it down and bring it to the minimal dose. Then you add on steroid sparing agent, either azathioprine or MMF or some other second line therapy which spares steroid, because you can't use high dose steroid for a long time. So this is initially a case of primary ITP because it has no other associated CTD features, no other abnormal smear, or there is no other leukopenia or anemia per se. So this is a case of primary ITP. You start with steroids since the platelet count is more. If platelet count is more than 30,000, still bleeding manifestation, you should still treat them. Any bleeding manifestation, you should still treat them. If the patient platelet count is more than 30,000, no bleeding manifestation, just wait and watch. You just monitor the platelet count. So that is the cutoff. Less than 30,000, you should definitely treat. More than 30,000, if bleeding manifestations are there, you should treat. If there are no bleeding manifestations, you just wait. A 24-year-old female presented with bleeding gums, and she had platelet count of 30,000 and hemoglobin of 7, and Coombs was positive. So a 24-year-old female with bleeding gums, and she had platelet count of 30,000 and hemoglobin of 7. So and Coombs was positive. How do you go about this? So this is a similar case where the platelet count is 30,000, but anemia is also present. But in this case, hemolytic anemia is present. So this is not a case of primary ITP. This is associated with some other the other hemolytic anemia is also. This is not no more primary ITP. There is other, generally in primary ITP only isolated thrombocytopenia is there. There is no secondary other any hemolytic anemia thing. So this is a case of primary. This is not a case of primary ITP. So there is other hemolytic anemia with platelet count immune thrombocytopenia is there. So what if in this case ANA is positive? Generally, when do we send an ANA is when when there is already existing rheumatological manifestation like fever, malar rash, serositis, arthritis. Then you send an ANA. If the patient doesn't have any CTD features, if you send an ANA, there are 5% population ANA is generally routinely positive. So only the ANA should be interpreted in the clinical background. Like if there is fever, malar rash, if it is fitting into the SLE criteria or something, if the patient is having SLE manifestation, you send an ANA. So if patient is having 30,000 and hemoglobin is 7, there is autoimmune hemolytic anemia, there is ITP, you send an ANA. If ANA is positive, but then you put a ACR ULR criteria, then you make it to score of more than or equal to 10, it is a lupus. But if it is coming somewhere between 5 to 10 or 6 to 10, it is not completely fitting into lupus criteria. Maybe it is an incomplete lupus or evolving lupus. If the same case ANA is negative, you might label it as Evans syndrome, where autoimmune hemolytic anemia with thrombocytopenia is there, where the cause is not. It's an Evans syndrome is a possibility. So if ANA is positive, but platelet count, hemoglobin, if other CTD features are definitely positive, it is a complete lupus. If it is not there, maybe incomplete lupus or evolving lupus is a possibility. So, but before sending ANA, always ask for CTD features, because it should be interpreted in the clinical background and not just routinely don't send ANA to all the patients. A 23-year-old female with bleeding gums on examination has splenomegaly and decreased breath zones and bilateral lower zones. Her platelet count is 28,000 and leukocyte count is 2,800 and HB is 11. So the same case. Generally, splenomegaly is not seen in the case of primary ITPs. So generally in the secondary ITPs, this is generally seen in the secondary ITP where the decreased blood zone, that might be pleural effusion, and her platelet count is 28, the leukocyte count is also low. So the patient has serositis, the patient has splenomegaly, the patient has leukopenia, the patient has thrombocytopenia. In this case, you send an ANA profile, and maybe this is a case of lupus. You should check for proteinuria, you should check for kidney function, you should check for any serositis, is there any neurological manifestation, and you should check for complement level, DSDN level to activity. So this is a case of SLE related thrombocytopenia. This is a secondary ATP. So secondary ATP can be due to the SLE, Sjogren's, scleroderma, rheumatoid arthritis, any HIV, any viral infection related, and any bacterial infection also can cause immune thrombocytopenia by a cross reactivity of autoantibodies. Any drug related also can cause, drugs can also produce cross immunity and produce immune thrombocytopenia. They are all secondary ATPs only. So this is the case of SLE related ATP. A 50-year-old male presented with HIV, present with altered sensorium, fever, and HB is 6.8 and platelet count is 20,000, and LDH is 800. Cystocytes are seen in peripheral smear. So this is the case of 50-year-old male. So HIV, the patient has altered sensorium, neurological manifestation is there, fever is there, and his HB is 6.8 and platelet count is 20,000, and his LDH is there. Definitely hemolysis is happening, and cystocytes are present. That is suggestive of microangiopathic hemolytic anemia. When you are looking for microangiopathic hemolytic anemia, you should always look into the cause of one. The most commonly we know HUS, hemolytic uremic syndrome. Other is TTP. Any coagulation, any DIC can also cause hemolysis, cystocytes. Any mechanical valves in the heart, that can also cause hemolytic anemia. So this all needs to be looked at. Like HELP syndrome can cause HELP syndrome. So any thrombus can cause, any small thrombus also can cause hemolysis. So these all need to be looked into the microangiopathic hemolytic anemia. In this patient, since the patient has neurological manifestation, fever, low hemoglobin, low platelet count, cystocytes are seen, mostly is the case of TTP. So if the patient has significant renal failure, this we might have labeled it as a HUS. So if the patient has a mechanical validation, maybe mechanical validated HUS. If the patient is a pregnant and elevated liver enzyme, maybe that is a case of HELP syndrome. So eclampsia can cause, pre-eclampsia, sometimes they cause microthrombosis, they can also cause hemolysis. But this is the case of TTP. So TTPs are generally divided into two, whereas congenital is called Upshaw-Schaumann disease syndrome, where the congenital Adam TS13 deficiency is there, where Adam TS13, before labeling it as a TTP, first what we need to do is Adam TS13 level is the one we check. If the activity is less than 10%, it is less than 10% only, it is a TTP. More than 10% is not a TTP. First we check for the Adam TS13 functional activity. If it is less than that 10%, that is an TTP. So TTP can be congenital or secondary. Congenital TTPs are generated due to congenital mutation in the Adam TS13. So what is the pathology behind Adam TS13 is why there is altered sensor, there is microthrombi. So generally Adam TS13 breaks down the multimers of von Willebrand factor so that there won't be excessive coagulation. If there is a defect in that, that causes excessive thrombi formation and all. So that congenital TTP is generally present at congenital level. It present at birth only. They have neurological manifestation like stroke or any altered sensorium like features, and they have low hemoglobin, low platelet count and all. So in them the treatment is only FFP. There is no point of giving plasmapheresis and all, because you can only give FFP and replace the Adam TS13 levels in the body. So generally these are accounts for only 10%. In 90% of cases, the cause of TTP is secondary to something else like HIV or some malignancy or post bone marrow transplant or some drug like ticlopidine or clopidogrel. So these are the 5 common causes: bone marrow transplant, malignancy, HIV, ticlopidine, clopidogrel. These are the common causes. Any cobalamin C deficiency sometimes can also cause TTP. So these are the common causes where they can cause some tacrolimus can also cause. So these can cause TTP as an acquired TP, where they form antibody against anti-Adam TS13 antibodies. So they decrease the activity of Adam TS13. That can lead to the TTP manifestation. In them, you can try plasmapheresis and along with steroid therapy and rituximab. So these are the three should be given together, because steroids will act on the short term. For the short term, plasmapheresis will remove the antibodies which are present, and rituximab will prevent the relapse. Recurring, because relapse is always dangerous in the case of TTP. The most common problem with the TTP is that 40% cases will have recurrence. So in them, to prevent them, rituximab is one more therapy that has shown effect in the preventing the relapse, so that the more frequency it occurs again, and the more risk of death. So to prevent relapse, rituximab is given. So this is the case of TTP. TTP, as mentioned, Adam TS30 is less than 10% activity. Congenital only 10% cases due to congenital mutation. Acquired is the most common cause, where HIV, malignancy, ticlopidine, clopidogrel, and some post-bone marrow transplant patient is there. The treatment is, in the case of congenital, is FFP, whereas acquired it is plasma exchange plus steroid plus rituximab. A 13-year-old child developed diarrhea and later developed bloody diarrhea in day 5 actually, but which subsided by day 10. but child developed AK and HB has HB of 7 and platelet count of 28,000. So generally this is patient developed diarrhea in the initial 2-3 days. In generally, this is a clinical scenario of classical HUS, where typical HUS is here, which is commonly associated with E157H7, E. coli or Shiga dysentery or some streptococci which can promote streptococcus pneumonia, which can promote neuraminidase enzyme also. So these are the common causes like E157H7 and also Shiga dysentery type 1 and also streptococcus pneumonia, which can promote neuraminidase. The classical history of E. coli E1, the typical HUS, initially 3 days they will have diarrhea, normal diarrhea, vomitings and all. On the day 5 they develop, day 5, day 6 they develop the bloody diarrhea. By day 10 it will subside. The whole diarrhea, bloody diarrhea, everything will subside. Then the patient will have to renal failure and this hemolysis like picture. That is hemolytic uremic syndrome. So the classical picture of HUS is the classical triad is hemolytic uremic syndrome. There is hemolysis, there is low platelet count, there is AKI. So AKI is a significant, whereas TTP AKI is not significant. And also unlike in this case 28,000, unlike in the case of TTP, platelet count is not significantly decreased in the case of HUS. So HUS platelet count are generally more than 60,000, generally 70,000, 80,000 will be there, whereas TTP will go very low, like 20,000, 30,000. So that is one of the differentiating feature. This is a case of a typical HUS where the supportive care is enough. The patient developed AK and all HBF. So this is a classical triad of HUS. Supportive care is enough. What is in the case of atypical HUS? So generally in the atypical HUS, they have more significantly like the mutations like factor H, factor I, factor B, which are the mediant of alternate complement pathway. There is excessive activation of complement pathway where they have a low C3, where the C4 is normal. So generally because alternate complement pathway involves only C3, C4 is involved in the classical complement pathway. Generally low C3 is there, C4 is normal in them. Factor H, factor by factor H, factor I, factor B, and MCP is one more protein involved in the atypical HUS. In them you can try plasma exchange, but plasma exchange is not much significant. You can try one more drug called eculizumab, which will inhibit the alternate C5 activation, which is a downward pathway of alternate complement pathway. So you classically is low C3 and normal C4, where the mutation is factor H, factor I, factor B. MCP is a good prognosis, factor B is very bad prognosis. In them you can try eculizumab, you can try plasma exchange, but not as significant benefit as you see in TTP, but eculizumab is the definitive drug in them. A 40-year-old male started on linezolid to cover MRSA infection, has developed a platelet count of 40,000 on day 3. So there are two scenarios. What if the patient developed the 40,000 platelet count on day 3, and what if the patient developed the platelet count of 40,000 on day 12? So if the patient developed the platelet count of day 3, it is not drug related. Generally drug related thrombocytopenia will take time. It will take at least 7 days or 7 to 14 days. The mean duration is generally 21 days. Generally day 7, at least day 5, day 7 it will develop. So that will take time. On day 3 it is developing, mostly it is related to sepsis related thrombocytopenia, not case of drug related thrombocytopenia. If it is developing on day 12, maybe the linezolid is a cause. If you stop the drug for 7 days, maybe if you stop the drug, that platelet count will recover in the 7 days time. So in day 3 it is unlikely to be a drug related thrombocytopenia. Drug related thrombocytopenia will generally take time, at least 7 to 10 days it will take time. So it is not a drug related, and if it is day 3 it is a sepsis related. If it is day 12 it is mostly a drug related thrombocytopenia. In the case of drug, you stop the drug, the patient will recover. A 28-year-old 35-week pregnant female developed fever associated with AK, and her HB is 7.2 and platelet count is 80,000. Her liver enzymes are elevated with AST of 300 and ALT of 450. So what is this case? So generally in pregnancy you know about HELP syndrome, preeclampsia, eclampsia, acute fatty liver of pregnancy. I am not going to discuss about the rest of them. The first thing is HELP syndrome. So this is a case of HELP syndrome. The most common mimickers of HELP syndrome is have seen one case recently in Usmania, where the patient had AK and hemoglobin is 7.1, platelet count is 38,000, and liver enzymes are little elevated, not as elevated as this. There are only 80 or 100 to 80 or something. So generally, and LDH is also significantly elevated in them. So there is also always a dilemma. So whether it is a HELP syndrome or some other microangiopathic hemolytic anemia like a typical HUS or TTP, which are also microangiopathic. HELP is also microangiopathic hemolytic anemia. This is always a discrepancy. What is the cause? Because the treatment generally HELP syndrome resolves with delivery. So on day 3 or day 3 to day 7 of after postpartum, generally HELP syndrome resolves. And HELP syndrome more have hepatic enzyme elevation, elevated liver enzymes, low platelet count, and platelet count is significantly low. And generally it will resolve with delivery. After pregnancy, after postpartum, day 3 or in a week generally it dissolves. Generally by day 3 or day 4 it resolves. But in the case of atypical HUS, where the cause is due to the pregnancy, is one of the trigger for the development of atypical HUS, where the complement mediated activation is the more. So in them that generally it doesn't resolve with the pregnancy, where the AK is more significant when compared to liver injury. So liver injury in them the patient has more of AK, and liver enzymes are not significant elevated. Liver enzymes are elevated, AK is more, and there is thrombocytopenia, and there is hemolysis going on. And generally it doesn't resolve with delivery. It goes on for few weeks to month. You need to give some eculizumab or plasmapheresis needs to be done. So here, if the patient has resolved this situation, might be because liver enzymes are significantly elevated. There is no they didn't mention the AK. Their AK is not significant, but the patient has more of liver enzyme elevation and more of low platelet count, more of HB. If it is resolving in delivery, it is case of HELP syndrome. If the patient has more significant AK and there is no liver enzyme elevation, maybe this is a case of atypical HUS. If the patient still has neurological manifestation, but the patient might have TTP also. So there is always a close call between these three cases. The treatment is deficient. I will help you. I'll tell you how to differentiate them in the later slides. But this is a case of mostly HELP syndrome might be resolving with delivery. A 40-year-old male who is kept in ICU and mechanical ventilation has been sent for routine CBP which showed platelet count of 40,000 and no bleeding manifestation. Generally what happens in ICU is we don't have any bleeding manifestation. We see random reports where platelet count is low, like 50,000, 60,000, but you repeat it again, it comes back normal. So this is because of the EDTA. We use EDTA tube for the violet tube which you use for that case. EDTA generally activates the GP2B3A pathway. So GP2B3 causes platelet coupling, so the platelet count will be falsely low. So you can see generally they don't give us graphs of this thing. Generally there is generally platelet flag is between 2 to 20 femtoliters. So if the platelet flag is crossing the 20 femtoliters, it uses a clumping. That because of the excessive GP2B3 aggregation, there is platelet aggregation seen. So generally in this case, if the patient is not having bleeding manifestation, previous day it is all normal, right? And they generally randomly the patient is developing 40,000 without any bleeding manifestation. You don't have any suspicion of any cause. Then you repeat it with heparin or citrate tube. So then the platelet count will again come back normal. So that is one more causability when you are looking, when you are not finding any cause for low platelet count. EDTA tube is one more cause. EDTA can activate GP2P3A, that can cause platelet clumping. So if you have graph available, always check for the platelet flag. Generally it is 2 to 24, 2 to 20 is generally femtoliters. It is generally present. Generally if it is crossing the 20 femtoliter flag is crossing, then it might be a case of platelet clumping is there. You need to repeat it with citrate or heparin tube. A 60-year-old male who is admitted for fracture in the surgical ICU was put on conventional heparin for last 1 week and has developed thrombocytopenia of 30,000. So you might have a label more like this is a fracture who is put on conventional heparin to prevent the DVT related cause. So the patient developed within 1 week. A patient developed the thrombocytopenia of 30,000. So you might have thought by now this is a case of heparin-induced thrombocytopenia. But how do you label a heparin-induced thrombocytopenia is important, because heparin-induced thrombocytopenia, when you are labeling it, so generally heparin-induced thrombocytopenia, if the patient doesn't have any history of heparin exposure in the last 3 months, generally develop after 5 to 14 days. So in general it occurs between 5 to 14 days. It occurs less than 5 days if the patient is previously exposed to heparin in the last 3 months. If he is not exposed in the 5 to 14 days is the mean time that the heparin-induced thrombocytopenia can occur. So that case generally the platelet count generally does not go below 20 or 30,000, generally doesn't go. And in these patients, heparin-induced thrombocytopenia, generally what people do is you go ahead and give platelet transfusion and all because platelet count is low. But this in heparin-induced thrombocytopenia there is excessive, there is an antibody second antiplatelet factor 4. So in them the risk of, because there is an increased aggregation of platelet and activation of platelets. So in them the risk of thrombosis is more when compared to bleeding in the case of heparin-induced thrombocytopenia. So that is called heparin-induced thrombocytopenia with thrombosis, that is called HI-T. So in them the important thing is not to give. You should never give platelets transfusion in the case of heparin-induced thrombocytopenia unless there is significant bleeding. So the risk of HI-T is more. So you should put them some anticoagulant, that is either fondaparinux or neuroanticoagulants like rivaroxaban or epaxaban or dabigatran you can use, or these are the things you can use. And at least for 2 to 3 months, if there is no thrombosis, if there is thrombosis, you should at least continue for 6 months. And so you should continue until the platelet count is generally normalized, and the platelet count generally normalized. You should still continue the anticoagulant if there is thrombosis for at least 6 months. If there is no thrombosis also, you should at least continue for 2 months in the case of heparin-induced thrombocytopenia, because they are more at risk of thrombosis when compared to bleeding per se. So do not generally routinely give platelet transfusion in the case of HIT because they have more risk of thrombus when compared to bleeding. And one more thing, you should always put them on anticoagulation at least for 1 or 2 months if there is no thrombus, if they, at least for 3 to 6 months if there is a thrombosis in the case of them. So generally you advise NOACs like Neuroral Levoraxavir, Dabigatran or Fondapornex can be given. So this is the case of apparent induced thrombocytopenia. You should always remember thrombotic risk is more when compared to bleeding risk. So I'll also ask one more question. What are the thrombocytopenia associated with thrombosis per se? So this is apparent induced thrombocytopenia with thrombosis. One more thing. There are many other causes where thrombocytopenia is associated with thrombosis, like APLA syndrome, where thrombocytopenia and thrombosis is there. Vaccine associated thrombocytopenia with thrombosis, one more cause. So like this, there are, and like one more, the PNH, paroxysmal nocturnal hemoglobinemia, where there is a hypoplastic. There is a decreased platelet production outside because of the autoantibodies present in the congenital cells, and there is in them the thrombocytopenia is associated with thrombosis. So these are the few causes you label. If you any causes you know where the thrombocytopenia is associated with thrombosis. So these are the few causes. APLA syndrome is one, PNH is one more cause, this apparent induced thrombocytopenia is one more cause, vaccine associated was one more cause, where thrombocytopenia is associated with thrombosis. So if you know any cause, let me know. So this is how you evaluate. Any platelet count less than 1,50,000 is considered as thrombocytopenia. Then you check for hemoglobin and white blood count. If it is abnormal, so if there is any change in the morphology, any dysmorphic features are present, any blast cells or any typical cells are present, if it is generally check for routine nutritional parameters like B12 deficiency or any iron deficiency, if there is anything is there, check for them. If it is not suggestive, if there is no nutritional parameters, if there is no Coombs test is negative, then if the Coombs test there is no autoimmune hemolytic anemia also, check for bone marrow examination. So after ruling of all the nutritional and hemolytic causes, like if there is any Coombs positivity is there or any other autoimmune features are there, if you rule out all of them, then look for bone marrow examination. If it is normal, then check for peripheral smear. If it is clumping is seen, redraw the sample in citrate and heparin because EDTA can cause clumping. So if there is fragmented RBC, you look for microangiopathic hemolytic anemia like any DIC, TTP, HUS, any valvular heart disease, you should look for them. If the patient has normal RBC morphology and platelet count is normal or increased in size, so then you check for drug-induced thrombocytopenia or infection-induced thrombocytopenia or idiopathic, like that is now primary immune thrombocytopenia or congenital. I'll mention a completely different thing about congenital thrombocytopenia, Von Willebrand's, Bernard-Solier. I'll make a different topic. How do you interpret that platelet aggregation test? I'll make a different video on that. But this is more of the common things we see. So generally, to label it as a primary immune thrombocytopenia, you need to label it as there is the RBC and the WBC and RBC parameter, only isolated thromb, no splenomegaly, no hepatomegaly, no lymphadenopathy, no other autoimmune condition, and all the other lineages are normal. So isolated thrombocytopenia is one more cause. Generally in ITP, I will tell you there generally larger platelets are seen. That is not a pathognomic per se, but it is more suggestive of ITP because of the congenitals are coming, like giant platelets you see in the smear. So that is more suggestive of ITP, not a definitive, because giant platelets are seen in congenital thrombocytopenias also. So giant platelets are suggestive. It doesn't mean definitively if an adult suddenly developing giant platelets is more of suggestive that patient might have ITP because congenitals are coming in place. But giant platelets are also seen in Bernard-Solier's gray platelet syndrome. There are many other conditions where you see giant platelets. So it is not definite, it is more likely. But there is one more thing, like you see in the hemolytic anemia where reticulocyte count is increased. There are also markers which you don't routinely do. Some reticulocyte markers for platelets are also there. Some congenital, like you can check for the thrombopoietin levels also. So they can also be used as a marker for telling that the immune thrombocytopenia is going on. Like in autoimmune hemolytic anemia, you check for reticulocyte count increase, no? In that reticulocyte index for platelet is also there, like not reticulocyte, some congenital index for platelet count is also there, where you can use it to detect where the excessive thrombocytopenia platelet lysis is happening in the periphery. So this is how you work up. Any abnormal hemoglobin and WBC lineage is there, you check for nutritional parameters and hemolytic causes and any CTD. If it is not there, any blast cells are abnormal, you check for bone marrow examination. Clumping is there, sodium citrate and heparin. Fragmented cells, microangiopathy. Only isolated thrombocytopenia, you check for drug induced or infection related or primary immune thrombocytopenia or congenital causes. So this primary ATP is not associated with any apparent associated condition. Secondary it is other associated. Drug related can be caused. Newly diagnosed, anything within 3 months is newly diagnosed. Persistent is 3 to 12 months. Chronic is anything more than 12 months. You can write it in your diagnosis. Newly diagnosed any less than 3 months. Persistent is 3 to 12 months. Chronic is more than 12 months. First line therapy is always steroid. So how do you define the therapy? If the patient has any critical bleeding or any life threatening bleeding is there, you go both with steroid and IVIG. IVIG is generally 1 gram per kg in the first day. So 1 milligram per kg I think in the first day. For 1 or 2 days you give, the effect will be seen in 2 to 3 days. So that lasts for 2 to 6 weeks. So any critical bleed is there, you go with IVIG with steroid. If there is no critical bleed, only minute gum bleed or menorrhagia is there, some peripatetic, you go with steroids. That is either you go for pulse therapy or 15 to 20 mg per kg body weight, or you go with 1 mg per kg. You continue it for 1 or 2 weeks, then taper it off over in less than 6 weeks. So second line therapies, you have thrombopoietin analogs like L-thrombopac, romiplastin is there. You can try other type like azathioprine, mycophenolate mofetil. There is vinblastine, vincrustin, which are previously used, not used right now. Dapsone is used, which is a androgen, which acts as androgen agonist, which can stimulate the platelet count. So you might be thinking, ITP is there, what is the role of giving thrombopoietin analogs? Because generally if there is a low platelet count, generally thrombopoietin will be generally secreted more and more. So it can actually helpful. What is the role of giving romiplastin and L-thrombopac again in the case of ITP? Generally, L-thrombopac romiplastin will have some immunomodulatory action also. They displace that megakaryocyte where it is generated. So it will displace that, it will activate the more and more. So you read about complete pathophysiology and let me know. I'll again mention it again. But it is interesting because generally in the case of there is a difference between how TPO is produced, how what is this EPO is produced. There is difference in EPO and TPO also, how they act, how they change with the platelet count anemia. That is an interesting concept. You go ahead and read how this L-thrombopac is being useful in ITP also. Go and read and come back to me. So then is the complete response. How do you define a response? Generally, anyone with less than 30,000, you start the treatment in the case of ITP. Anything more than 30,000 without bleeding manifestation, generally give a wait and watch approach or manage symptomatically. So anyone with less than 30,000, you go and start treatment. Any response is defined as any doubling of platelet count. Any, like the patient is having 10,000, 20,000 is a response, and any count more than 30,000 is also a response. Complete response is any count more than 1 lakh. Partial response is anything between 30,000 to 1 lakh, or any doubling is a partial response. So complete response is more than 1 lakh, partial response is 30,000 to 1 lakh. So any response is defined as doubling of platelet count or platelet count more than 30,000 is response. Relapse is if the platelet count is again falling below 30,000. Refractory is patient is not responding to despite any treatment, then you go for splenectomy is the only option in them. Refractory disease, the only thing, the patient is not responding to any drug. You give IVIG, you give steroid, you give rituximab, you give cyclophosphamide, you give MMF. No patient is not, that splenectomy is the only option in them. So this primary, newly diagnosed 3 to 12 months is percent, chronic is more than 12 months. Response is any doubling or more than 30,000. Complete is more than 1 lakh. First line is always steroid. If he is having critical bleed, add on IVIG too also. You give the steroid full dose for at least 1 to 2 weeks, like that is 1 mg per kg, then taper it over within less than 6 weeks. Then you add steroid sparing agent like azathioprine or MMF or something. Generally, you can combine them also. Like steroid plus MMF is also an option, or steroid plus azathioprine is also an option, so that you can taper it quickly. So this is the patient, adult with any bleeding site, any platelet count you should be asked. Any platelet count less than 20,000, you give IVIG with critical bleeding. Platelet transfusion should be given, IVIG should be given, glucocorticoid should be given. So the platelet count is 20,000 and the patient does not have any significant like severe bleeding, is there, not life-threatening bleed. You give IVIG and glucocorticoids and little. If the patient is only having minor bleeding, like not significant bleeding is there, only you give glucocorticoids. Only severe and critical bleeding you give IVIG, otherwise you only give steroids. And platelets are only given if there is like only if needed, like less than 10,000 you generally give platelets to make them normalize. If the patient is not having any significant bleeding manifestation like 10,000 to 20,000, you can generally give steroids and wait. So if there are bleeding manifestation with despite of giving steroid, you can try giving platelet count, but generally don't routinely go ahead and give platelet count for any less than 10,000 you can give, but you can less than 10,000 with bleeding manifestation, definitely you should give. Less than 20,000 with significant bleeding manifestations also you can give if the patient is having some, like if you or the patient is not having like you said, this is the day one the patient might take for response to come in the case of IVIG and glucocorticoids. So, but generally don't routinely go ahead and give transfusion for everyone. So generally if there is any critical bleed and patient count is less than 10,000, then you can give platelets, but routinely in the case of 20,000, 30,000 also don't give platelet transfusion. 10,000 to 20,000 also, if the patient doesn't have any bleeding manifestation, you can generally wait for steroid response or IVIG response. Less than 10,000 you might give for the caution, but 10,000, 20,000 if there are no bleeding manifestation, generally don't give. But if there are bleeding manifestation, you can give few two or 3 RDPs and wait. So this is the again the algorithm telling how to go about the therapy. So initial therapy is always glucocorticoid. One more if the critical or severe bleed is there, so you can give IVIG. So one more therapy is anti-D. So anti-D is one more therapy. Anti-D, for giving anti-D, that is anti-RH. So anti-D, for the patient to give anti-D, the patient should be RH positive. Patient should have splenomegaly and HB should be more than 10. How it activates is if you give anti-D, it will cause hemolysis because the RH positive, for RH positive patients you are giving, no? So it will utilize all the complements and macrophages. So there won't be any complements and macrophages to act on platelets. So at the expense of hemolysis, you are conserving platelets. So that is one more thing you can do anti-D. That is an interesting phenomenon where you are causing hemolysis and conserving the platelets. So anti-D can be given in those patients. That is also act in the initial therapy. Then you can go for subsequent therapy like thrombocytopenia or rituximab or azathioprine or MMF. In the case of refractory, you can give splenectomy also. So if generally platelet count are more than 30,000, don't give anything. So but if there are bleeding manifestation, definitely you should give. So that is what this is about. This is the treatment of ITP. Platelet transfusion less than 2,000 you give. If there are bleeding manifestation, even at any bleeding manifestation, you give platelet count at some amount. But if the patient doesn't have bleeding manifestation more than 10,000, you can generally wait for the therapy response. So this is again. So whom do you manage inpatient? How do you manage outpatient? So in adult patient, anything newly diagnosed less than 20,000, you should manage it inpatient. If the patient is already known case of ITP from last time, so established diagnosis, you can manage even less than 20,000. You can manage it outpatient if there is only minor or mucocutaneous bleed with steroid therapy. So this is the thing. Even if the minor bleeding manifestations are there, any mucocutaneous bleed, you can just give steroids and you need not give platelet transfusion per se. So they can be managed outpatient. More than 20,000, definitely outpatient. Newly diagnosed or established diagnosis, definitely outpatient. Only newly diagnosed less than 20,000 with the minor bleeding manifestations only you admit and see. So if critical bleeding is there, definitely anyone will admit. So established diagnosis all outpatient only. So this is one more important patient. If the patient is already established diagnosis, even mucocutaneous bleeding is there, asymptomatic bleeding is there. So in them the patient can be managed outpatient with steroids. No need to routinely transfusion in the case of minor bleeds. In the case of 20,000 all platelet count. If the patient has less than 10,000, you can transfuse, but generally don't routinely go on and transfuse for everything. So this is the case. All more than 30,000 manage with observation with asymptomatic. If patient has less than 30,000 with minor you should give treatment with steroids. More than 30,000 no symptoms and minor mucocutaneous bleeding you generally manage with observation. So these are the first line manifestation as I mentioned. So this is the thing. So all steroids should be steroids 1 to 2 milligram per kg or 0.5 to 2 milligram, and steroids should be tapered in the short course, less than 6 weeks should be tapered. So this is the therapies. Generally in Western countries, this is the ASH guidelines, American Society of Hematology guidelines. Thrombocytopenia blocks they use routinely, but we use of more of steroid sparing agents like MMF or azathioprine. We use those things, Lapsone or something like that we use. But we do because TPO is L-thrombopac is very costly and costs around 20,000 per month. It should be taken empty stomach before 2 hours and after 2 hours you should not eat anything. So that is a complicated thing we do not routinely get. In the case of some cases we use ITP, you can use, but if they're affordable, but that is also an option. So this is how in the first uses the ITP within 3 to 12 months. So patient high value and achieving durable response, like the TPO has high durable response. So thrombopoietin receptor agonists like L-thrombopac or romiplastin can be used. Romiplastin is injection where you give once weekly, whereas L-thrombopac you should take daily tablet. Around 50 mg tablet is available. So rituximab for avoiding the long-term medication. The rituximab is an injection where you give once weekly for 4 weeks. That is 375 mg per meter week. The response will last for at least 6 months to 12 months. So 2-4 weeks it is done. But the response is better with the TPO when compared to rituximab. But rituximab it will again recur again. So the response will only last for 6 months to 12 months. So more than 12 months, patient is looking for the durable response, like checking durable response. Always TPO is preferable. Or if patient is willing to go for surgery, you can go for splenectomy. But right now the indication for surgery in the case of present is only refractory. Patient is not responding to any drug, because splenectomy, it will itself pose for the risk of infections like Haemophilus influenza, meningococcal infection. So it is not routinely advised to remove the spleen in the patient. You go for TPO receptor agonist. If the patient is not willing to take the long-term medication, you can go for rituximab therapy for 6 to 12 months. That is 375 mg per meter square. If the patient is despite of all these, patient is not getting any response despite of TPO, second like azathioprine, MMF and rituximab, you can go for splenectomy in the refractory ITPs. So these are the first line prednisolone. The response comes, when the response comes is also very important. So that is how you treatment. So in the first day, the patient is coming on the first day with bleeding manifestation, you start them on steroid. The response won't come on day one. So you need to give platelet supplementation somewhat. The patient count is less than 10,000, and if the patient is having critical bleed, you need to give IVIG, because IVIG response come in 1 to 3 days. Even anti-D response come in 1 to 3 days. So if the patient on day 2 and day 3 is having minor bleeding like melena or something, you need not transfuse platelets in them. The response will come in them. So that is how you wait the patient. If on day 1, if the patient is having significant hemorrhage, menorrhage or significant bleeding, you can transfuse and wait. Like on day 2 and day 3, it will help to cover up for till the steroids take over. So that is what I am trying to tell. So this is what IVIG and anti-D and splenectomy are the one which have day 1 response or day 2 response. So peak response of IVIG is in 2 to 7 days, lasts for 6 weeks, almost 2 to 6 weeks. So these are the other, rituximab can be used, L-thrombopac, romiplastin, avatrombopag, TPO agonist, romiplastin, these are all TPO agonists. Other like azathioprine, danazol. Azathioprine is also 1 mg per kg, like 0.5 to 2 mg per kg. You can use 1 mg to 2 mg per kg, 50 mg to 100 mg is routinely used. And danazol can be used. And MMF, vinblastine and crastin are previous drugs that are used in the case of ITP therapy. So the response when is coming in steroid in the prednisone 4 to 14 days, the response, peak response is in 7 to 28 days. So this is important to weigh. So whether you should platelet transfusion or whether you should try IVIG. If there is critical bleed, you should definitely give IVIG or anti-D. So if the patient is having minor, like significant, not minor bleeding, you can wait and watch. If the patient is like will get response in day 3 or something, is on day 2 or day 3 of steroid therapy. So these are the other causes where you can have secondary ITP like Evans syndrome, autoimmune hemolytic anemia, autoimmune lymphoproliferative syndrome. I'll learn about ALPS when I discuss about hematology, rheumatoid arthritis, SLE, HIV, Helicobacter pylori. So H. pylori has notorious correlation, association with ITP. So many of the patients with ITP have H. pylori infection. So one of you can do a study how many ITP patients have H. pylori positivity also. So H. pylori is also one. If H. pylori is positive, you can treat them with that H. pylori regimen, H. pylori kit. EBV, hepatitis C is associated, HIV associated, Zika, lymphoma, gold, measles, nivolumab, pembrolizumab. These are all medications and drugs. They can also cause secondary ITP. There are hundreds of the drugs that can cause ITP. So this is the microangiopathic hemolytic anemia. The patient, based on the age, if there is infant or child, bloody diarrhea is there, you should always look for Shiga dysentery or classical typical HUS. So otherwise congenital ITP is a congenital TTP or congenital HUS is a possibility where patient TTP will have neurological manifestation, whereas HUS will patient have more of renal manifestation. So the patient has bloody diarrhea, always Shiga toxin HUS is possible. If patient is adult, kidney injury is minimal, it is TTP. Kidney injury is present as acute, it is a drug induced or Shiga toxin related HUS or complement mediated HUS. So some metabolism can also be a possibility, like any defect in the homocysteine pathway or something that can cause. So if the patient does not have a underlying condition is like DAC is there, some infection is there, some malignancy is there, HELLP syndrome is there, that should always be looked for in the case of the other underlying causes should be looked for. So this is the 4T score which we use in the case of predictability of heparin-induced thrombocytopenia. So acute thrombocytopenia, platelet count decrease more than 50%, or nadir is general. The lowest platelet count is more than 20,000. So this is the thing, generally platelet nadir does not go below 20,000 in the case of heparin-induced thrombocytopenia. So this is the scoring system, timing of onset, day 5 to day 10, more than 10, less than day 4. So with recent heparin exposure is there, definitely it can occur, or day 1, on day 1 also if the recent heparin exposure, that is within 100 days heparin exposure is there, it can occur on day 1 also. So if there is any onset thrombosis or any progressive thrombosis, there other cause of thrombocytopenia are present or not. If the high risk 6 to 8, anything more than 6 is high risk, 4 to 5 is intermediate, low risk is 0 to 3. So in heparin-induced thrombocytopenia, it is always important to start DOAs, any anticoagulant, because platelet should not be routinely transfused because the risk of bleeding is very less. Thrombotic risk is more, and anticoagulant should be continuous for at least 1 to 2 months or 1 to 3 months for there is no thrombosis. If there is thrombosis, at least 3 to 6 months thrombosis should be done. This hit scoring is important for identifying the risk, how much risk of the patient is at a hit. So this is a hit. So it can occur only in the day 0 to 5, the last 50 100 days of exposure is there, and generally it occurs between 5 to 14 days. So heparin-induced thrombocytopenia with thrombosis is one more phenomenon that occurs in 50% cases of heparin-induced thrombocytopenia. That way you should put on oral anticoagulants. So these are all the drugs that can cause isolated thrombosis, apixaban, acetaminophen, amiodarone can cause, ampicillin can cause, ceftriaxone can cause, all penicillin class of drugs can cause, furosemide can cause, gold can cause, heparin can cause, lorazepam can cause, phenytoin can cause, piperacillin, all penicillin cause, carbapenems also can. Quinidine is one more drug that can cause, rosiglitazone can cause, vancomycin can cause, linezolid can cause, cotrimoxazole can cause, olenceron can cause. There are many drugs, there are hundreds of drugs that can happen in this. One exception is epciximab. Epciximab is the only drug which can cause thrombocytopenia within 24 hours of starting of drug. Other all drugs take time. It's like generally mean duration is 21 days. At least week to 2 weeks is the minimum time that can take for the drug-induced thrombocytopenia. Only exception is epciximab. Epciximab can cause thrombocytopenia within 24 hours of starting of drug. You stop the drug, the patient will be fine. So these are the difference between TTP and HPS. TTP has hemolytic uremic syndrome. Both has hemolytic renal dysfunction, thrombocytopenia, which is more significant when compared to HUS. CNS symptoms are fever is there. So this is one more thing. So this is one more thing I told you in diarrhea, where there is no fever and the patient is having bloody diarrhea, is one more indication where you should not start antibiotic because it can provoke the typical HUS. So generally bloody diarrhea are associated with fever. In the case of Shiga dysentery or E157 H7, the patient will not have generally more of fever manifestation. So in them, wait on antibiotic therapy because patient will be at risk of HUS because you give antibiotic, the patient more toxins will be released into the body. It will precipitate the more of HUS. So this is one more the pregnancy case we discussed now. So this is how you differentiate. These are all close mimickers. Any week more than 37 weeks. So these are all three. HLP is a differential, TTP is a differential, HUS is a differential. How do you differentiate? So generally TTP occurs in the mid trimester. So HUS generally occurs after postpartum or early just before delivery. So CNS manifestations are more significant in the case of TTP when compared to HELP. Renal failure is more significant in the case of HUS. Hepatic dysfunction is definitely present in the case of HELP. Generally it is very mild in the case of TTP HUS. And fever is generally nil in the case of, might be present in the case of TTP, generally nil. Generally HUS also doesn't have any fever or something. So TTP generally will have fever, generally this won't have. And purpura is also very rare. And decreased platelet count is only mild in the case of, mild to moderate in the case of HELP, and moderate in the case of HS. Severe thrombocytopenia is seen generally in the case of TTP. In that case there is severe thrombocytopenia, there is fever. That might be a case of TTP where maybe you didn't notice neurological manifestation. So AST-LT is more in the case of LDH, which is generally seen in the case of HELP syndrome, which is not seen in the case of TTP HUS. LDH increase is seen in the case of mild in the case of. One more ratio that can be is LDH by AST ratio. So LDH by AST ratio is more than 25 in the case of HUS and TTP, where it is not less than 20, generally not significantly elevated in the case of HELP syndrome. So generally it resolves with postpartum in the case of HELP syndrome, not resolved. So HELP syndrome more significant elevated liver enzymes are there, not minor CNS manifestations or renal failure or fever or anything is there. Generally it improves with postpartum. Where in the case of TTP, significant thrombocytopenia, significant neurological manifestation is there. And that is one more important. In HUS there is more of significant renal failure, no neurological manifestation, only moderate thrombocytopenia is there. That is no liver enzymes elevation is there. So that is HUS. In TTP you go of it with plasma exchange and steroid plus rituximab, whereas in the case of HUS, if it is typical you wait and watch. In atypical HUS you go for plasma exchange, but you can also try eculizumab. HELP, the treatment is delivery. That is the end of presentation. Thank you.